Here with Dr. Virgínia Hernandez-Gea. She is one of the greatest experts in the world in portal hypertension from Hospital Clínic de Barcelona. And we are doing some quick questions for her. First of all, Virginia, if you have a patient with portal vein thrombosis without cirrhosis, should we bend the varices before anticoagulation, or we can anticoagulate without bending the varices?
So I think we always need to look for varices because they can appear like very soon after the portal vein thrombosis. So we always need an endoscopy and see if we have varices. My recommendation would be put the patient on non-selective beta blockers. I do think that non-selective beta blockers can help in preventing bleeding, and then you are not messing up with the banding that also in a patient that will need to be anticoagulated. And what do you do? Do you stop the anticoagulation for the next banding? Yes or no? It's more complicated. So putting the patient on non-selective beta blockers right away, titering the dose, and then you start anticoagulation. It can only delay a little bit the start of the anticoagulation, and it's my preferred treatment of choice for varices.
Perfect. Do you have a preferred medication for anticoagulation in patients without cirrhosis?
I do have more experience with vitamin K antagonists because in Spain it's difficult to prescribe DOACs in this setting, but there are like more and more data coming from other countries showing that DOACs are also a good treatment for these patients, and the efficacy is similar to vitamin K antagonists. I will prefer vitamin K antagonists because I do have more experience and we know these drugs for many years, and we know the complications and the safety profile, but I think it's going to change in the future, because especially in those patients without cirrhosis, young patients, that vitamin K antagonists, they require a lot of it's difficult, and if they travel, if they eat this, or if they change the diet, so it's more difficult for them, and we have data showing efficacy and safety. So I think this is going to change, and probably the next recommendations would be like equally you can choose whatever you have available, vitamin K antagonists or DOACs.
Perfect. And when it's time to stop anticoagulation and think on recanalization, when it's time in patients without cirrhosis?
In patients without cirrhosis, we do only recanalization if they do have portal hypertension complications, refractory complications, if they have ascites, if they have bleeding, because those techniques are complicated, can have side effect and even mortality depending on how complicated things are. So by now we only offer that in patients with refractory complications of portal hypertension. So we do anticoagulation, and then even if the patient do not recanalize, if the patient is asymptomatic, I would continue anticoagulation and I wouldn't change. Only in those cases with complications or portal cholangiopathy that is very intense, and this kind of things, bleeding or ascites.
Perfect. One last question. We saw your lecture minutes ago, and you told about some studies about the thrombus itself, and also using factor VIII to try to see patients who will rethrombosis. Can you tell us about that studies?
Yeah, this is a little bit linked to the previous question. We have the feeling that sometimes, so initially years ago, the guidelines were not recommending anticoagulation in the setting of a patient with without cirrhosis and not underlying thrombophilia. But we had those patients coming to the clinic with another thrombosis, and then we decided to study that. So gathering a cohort of patients without underlying thrombophilia, we could see that there is risk of presenting rethrombosis during follow-up. So there is this risk even in the absence of thrombophilia, and we were like looking for factors able to identify where the risk concentrates, and here factor VIII more than 150% can help you to identify those populations. And now we have two studies, the initial study and now a second study that is submitted for publication in an international cohort checking factor VIII, and it seems that if the patient does not have other thrombophilia, having a factor VIII more than 150 gives you risk of rethrombosis, and anticoagulating them would be appropriate in this patient.
Very interesting.